The following events were recorded as they happened at the Hospital for Sick Children in Toronto. In this episode of Life's Little Miracles, Kaylee's open heart surgery. Five-month-old Kaylee was born with tetralogy of Fallot, a malformed heart. Her condition results in dangerously low oxygen levels and a rapid heart rate.
I'm just going to measure, for oxygen.
Kaylee must undergo surgery to repair her pulmonary valve and close a hole in her heart if she is to survive.
Okay, so
Today, she will be examined to ensure she is healthy enough to endure both the operation and the difficult recovery that will follow as her body tries to adapt to the heart repair.
Yeah. So I was just reviewing some of the notes that we got from the clinic visit. So I understand that Kaylee was diagnosed while
I was pregnant, 4 months.
Okay. And did she have any problems when she was born?
No.
Okay. And so how has she been since going home?
Good. She really, I guess there was one episode that we thought that maybe she had a blue spell, but
Did
but
you
I
have to
think
put her knees
fine.
to her chest at all?
Yeah.
And she came out of it okay?
Yeah.
Okay. And do you remember how long it lasted?
Do you?
Seconds, minutes?
Yeah, no,
Seemed like hours.
Seemed like hours. I'd say more minutes.
Sure.
Than that.
Okay.
No.
How is she when she's active and playing? Does she get sweaty or does she get blue to you at all?
She's the older she gets, the more I notice that she gets blue around the lips, especially if she's upset about something.
Okay.
And as far as I just noticed that she's getting clammier.
Okay. And is that when she's active or
That could
just
be both.
anytime?
Yeah.
Okay. So I'll examine her. I do need her to lie down just for a minute so I can feel her tummy and her little pulses in there. Just very gently, of course. Does that tickle your tummy? Does that tickle your tummy? Okay.
Oh.
Actually, while she's just like that, I'll have a listen. She's quiet. Great. I'll see you after the operation. I'm part of the team
Oh,
that
are
will be
you
caring
okay?
for her when she comes back
All
up
right.
to us.
Okay.
After the ICU, so I'll see her then.
Say bye, Paula, for now.
Bye-bye.
Thanks a lot.
You're welcome.
So she's going to be sitting on the bicycle seat,
Okay.
and then you're going to pull the arms up in the air like that.
Oh, okay.
And then then we're going to close this thing over.
Oh, and a test.
Yeah.
She's fine. Oh, she's eating it.
Oh,
Does that taste good?
okay, that's it. She's done.
Is she done?
Yeah, she's
Let's get
just
rid of this.
hold hands like that for me, please.
Oh,
And she's all
dear.
done.
Better pull it back.
And just wait outside for me.
Nice to meet you. And this is Nick.
Hi. Can we go in?
Yes.
Okay. So I'm sure you've gone through a lot of teaching, so I'm sure
Yes.
you know a lot of what I'm gonna say.
Right.
How was the diagnosis?
It was
made?
the fourth, when I was 4 months pregnant, that's when
Okay.
they did the ultrasound and had discovered that there was something not right with the heart.
Okay. The problem is that there is a hole between the right and the left heart,
Right.
between the ventricles, and there's also a narrowing of the exit of the right ventricle. And the purpose of this surgery is to closing the hole between the two ventricles with a patch. We also open up the arteries, the pulmonary artery,
Right.
and we look at the valve inside and just make the pulmonary arteries bigger. The risks of the operation: lung problems. After the surgery, she's gonna have tubes,
Right.
and some tubes can to collect the fluid around her heart. She can have pleural effusion, so and lung infections also,
Right.
and bone infection are also complications of a surgery like that. I'll ask you to read this. This is the consent
Okay.
form, and it says that I've explained to you the surgery and the risks, and that you agreed to it, and you have to both sign for it.
Okay.
Okay. Very good. So the surgery is planned for Thursday morning. Do you have any more questions? No. Are you okay?
What's up? When will they start to get her ready?
We're gonna start getting her ready now.
Okay.
Actually.
Okay.
I'm gonna just take some vital signs and get her already in her outfit.
Yep.
She a good girl?
Yeah, really good.
Did you have any questions?
I don't think so.
Hey, Kelly Bear?
Hi, I'm Dr. Holtby. I'm on the staff nurses. Hello, sweetie.
Who is that?
Do you guys have any questions?
I don't think so, no.
No, you've been talked to endlessly, I'm sure.
I love you. I love you, yes. Don't cry. Don't cry. No.
All right, Dolly Doo, come on. There we go. There we go, there we go. That's your copy? Yeah,
Yes.
that's your copy.
Yeah.
All right, let's go find the rest of the troops, shall we? Come on. It's not good. Eh? And you get slimed. When we use
put it right under the warming blanket, which I can come from the other side and do.
So Martine, you went off the bottom, right? 'Cause that's the lowest.
Yeah,
You're not okay.
that's good. So that's just sawing open the breastbone. So the first thing we do is get ready to go on a heart-lung machine. And that allows us to completely bypass the heart and give blood to the brain and the body while we stop the heart. Okay to divide your lines?
Go ahead. Okay to transfuse that blood back?
Yes, it is.
Thank you.
Okay. That's good. I'd like to look at the pulmonary valve first. So now we're just opening up the housing around the valve to see how the valve looks inside. Sometimes the housing's bad, but the valve itself is better than the housing. So the bands always run along that line right there. Make sure you're far enough away from the aortic valve. You really have to be careful of that right corner. It's really strange. Pull that up, that's good. There's the valve, and to me that looks like a valve we can work with, so we're going to spend a little bit of time fixing it. The opening of the valve is small, but the very base of the valve, down where it attaches to the heart, is a pretty good size. So we slit it open a little more. There you can see we've slit it open. That's given us a couple more millimeters. and cut into the ventricle just a little bit. And that's a much better looking valve. So I'm still not sure it's going to work, but we at least have a chance at it. I'm putting this patch in. This is a patch we'll put in. It's just about right. Mosquito. So now we're going to take the clamp off to the aorta so the blood can go back to the heart, and the rest of the operation we'll do with the heart beating. Drop your flow.
Slow down now.
So now blood's going back to the heart. In a few minutes it'll start beating automatically. And you can see the heart gently starting to beat again. The right heart is strained though.
She isn't really a substrate.
No, but she has small PAs. It looks to me like it's stressed a little bit. Wow, blood pressure is 100. Let's measure it now.
This is about the level of the valve.
It's no better.
Okay, let me see. I can see the PAs.
Well, the only thing is there orifice stenosis of the branch PAs that we can deal with. That's all. And then maybe I should go, if we're going to have RV pressures this high, maybe I should leave an ASD.
Yeah, that might be an idea. Yeah, it looks really good. Maybe for a second. It looks really good.
It's hard to believe you can get that to look any better, isn't it?
For a second. It looks really good.
Pick up, please.
I'm letting it kind of drift down.
Put the
11.
chest tube in and pacer wise. I'm going to go make sure things are okay over there. Yeah. Kaylee seems to be doing okay.
Good.
We found what we expected and in some ways a little bit more. We fixed her tetralogy without any difficulties. Her own rhythm seems to be working.
Okay.
We closed the hole in her heart okay. Her pulmonary arteries, which we knew going into the operation, her branch pulmonary arteries are small. Each of the branches that goes to each side. And that is proving to make the right heart need to work harder than what I normally would like it to work.
Okay.
And the blood pressure on the right side is higher. Normally I'd like to see it around 40. It's up in the 50s, even the 60s sometimes. So at the moment she's doing fine, and we're going to watch her very closely. I'm
Anything for us to be alarmed about?
If she doesn't look like she's doing exactly the way we want to, then I may want to take her up to the cath lab and look at those arteries with x-rays to see whether there's something more I can do for them surgically or not.
When are you going to know about the pressure? Like, are you talking now? Are you talking next week? Are you talking
whether
next month?
It comes down with time? The real issue is, does the body tolerate that kind of pressure? And that's the issue. Does she tolerate it in the short term when we've changed her physiology as much as we've changed it?
She's still got ice. She doesn't feel, she still feels warm. She's fine.
Oh, I know.
All this stuff has to hurt so much.
Morning, Doc.
Good morning.
How are you?
Good, how are you?
Hello, I'll get out of your way.
Hi, how are you? Pressure has been around this sort of range. Trying to keep the systolic around 90.
Mm-hmm.
Cooled off a little bit around this. She said around 7. And she's a degree 1.
And we tried to wake her up.
No, she still wants to relax. She she's been getting morphine 40 mics and then midazolam boluses because her pressure was going quite high, and she's
Well, she looks fairly good, but clearly hasn't fully adjusted yet to the new arrangement. So, I mean, what we see is that her heart is coping, but it hasn't gotten to the point where it's acting normal yet.
Right.
And what we would hope to see over the course of the next day or two is that it starts acting more normal.
meaning.
Meaning that she just needs a little, the numbers that we see read a little more normal. Her heart rate comes down, the amount of fluid that we have to actually put in the heart for it to pump the appropriate amount of blood would be a little bit less. And it's just going to take a few days to play itself out, I think.
Back. How are you guys doing? So I had a chance to at least talk with the sonographer who did your little one's echocardiogram. Okay. And it sounds like everything's clear, and that there's no obvious obstruction. Okay. Everything looks clear, and then her repair actually looks quite good.
Oh, does it? Good.
And again, she's developed this chylothorax, which is this fluid collection. There's like a backup, and then you get release of the lymphatic fluid into the space around the heart and around the lungs. It's a little bit stressful. Most of the time we're able to get on top of it with other things. So, but she's doing well, that her repair went well and that everything along structural lines and functional lines looks great. That's all in her favor.
Right. Over the last week I've learned to try to take one day at a time.
Right. No, that's the best thing right now. Could have been easier, but
We'll get through this.
she's just giving us a little challenge.
Yeah, no, from day one she has,
There
so
you
this
go.
is no different.
Anyways.
There's my smiley bear. There's my smiley bear. So wait here. There we go. Let's have a listen to your lungs here. Can we sit you up for a listen? Hi there, smiley bear. You sound good. So since Thursday, the x-rays have been fairly favorable. They haven't had any significant
No big
accumulations.
increase?
No, that they're worried about. There was a small one in the beginning, and I think you said the last one was better, right?
Right.
So, and then, we'll carry on watching the x-rays to make
Okay.
sure she doesn't reaccumulate now that she starts the collagen.
Hey, Kaylee, let's do this, then you can go
Okay,
home.
let's go, Kaylee.
Oh, sorry.
She's gonna act strange in her own crib.
Yeah, she is. Are you excited to go home?
Yeah.
There. Give them a smile. Yeah. Oops.
Yes, you are.
So the home care nurse is available. Yeah, tomorrow.
Sunday, right?
Yeah. She'll just probably gonna lock it and then change all the tubing on Monday.
Okay.
Yeah.
No, not back again.
I'm gonna turn on some music. Listen to this, listen. Can you hear? Listen to this. Can you see the light? You're used to this light. Yeah. Her heart rate is about 132 and a perfect saturation of 100%.
There we go.
I mean, is that what you asked for? A perfect child?
She looks great though. Look at her. Hi, Billy.
How you doing?
Do I get a smile
today?
Okay. So since discharge, she's done well. She's been pretty happy. She's a happy baby.
It depends on who you talk to.
Okay. Wait, and is she breathing fast at all for you guys?
No.
She's been pretty comfortable. So those are all good signs. What I'd probably do today is actually stop the captopril.
All right.
Either of the medications, like I said, we put her
Little
on the
by little,
medications
right.
with the thought, maybe something is going to work here. But that she's doing so well, I'd be apt to go ahead and stop one of them, okay? Yay.
2 down, 1 to go.
I know. All right.
All right.
Anyways,
Thank
it's
you very
really
much.
lovely to see you guys. I'm really happy that she's doing so well.
Yeah, all right.
Okay.
Great, thanks a lot. Thank you.
Three months after surgery, Kaylee no longer suffers from low oxygen levels or a rapid heart rate. Kaylee's progress will be followed by cardiologists, but doctors are hopeful she will continue to thrive. The following events were recorded as they happened at the Hospital for Sick Children in Toronto. In this episode of Life's Little Miracles, Kayla's scoliosis surgery and Lisa's kidney operation. "15-year-old Kayla Kelly was born with spina bifida, a malformation of the spine that has left her paralyzed from the waist down. As a result, Kayla has developed scoliosis, a severe curvature of the spine that causes her pain and makes it difficult for her to sit in her wheelchair. Without surgery to straighten her spine, the scoliosis will become worse. Today, Kayla will undergo final testing to ensure she is healthy enough to endure the 12-hour surgery she needs to relieve her pain and continue the active life of a teenager.
Okay, here we are. Blood work. Oh! Yucky.
How big? Just a prick again?
No, I'm afraid it's the whole thing. This isn't the fun part, is it?
Okay.
She has very tiny veins.
She does. So the small veins is where? Up
Yeah.
here? Okay, there's a little one there. Okay, sweetheart.
I hold really still, right?
So, do you want me to count to 3? No? Don't count? Okay, don't move though, don't move. Anything except to move, okay? All right.
Oh, no.
Okay, here. 1, 2, 3. We're done. Okay, it's done. All right, it's done.
Okay, Ann.
Oh, man.
Next is X-ray.
Can I kick the door open?
Can you kick the door open? No, you cannot kick the door open.
Yeah. Who's gonna pull the legs?
Can Mom do it?
Sure. How you doing? I'm Franco. I'm with orthopedics and Dr. Wright. We're gonna pull on both your ends, okay?
I'll smile for this X-ray.
You are, huh? You gonna smile for me?
All right, just relax. Just let everything go nice and loose, and we'll pull gently.
Okay, don't move. Okay. Don't move, don't move, don't move. Breathe. That's better. Okay.
There's a whole curves at the bottom.
All right, then.
4-month-old Lisa Simmons has been diagnosed with hydronephrosis, a condition in which urine becomes blocked inside the kidney.
Found it on one of my ultrasounds. Actually, first ultrasound, they said her kidney looked larger, and then they did a few more ultrasounds.
If left untreated, Lisa could face painful and dangerous infections, and her mental and physical development could be impaired. Today, Lisa will undergo surgery in the hope that doctors can save her kidney before there is permanent damage.
About 7:30, 20 to 8, you'll be going downstairs and meeting the anesthetist. Remember we were talking about that? And he'll tell you about the medicine they use to make Lisa go to sleep. Then they'll carry her in the operating room. And that's, you folks will wait down the hall. That's the hardest part. Fortunately for her, she'll just be interested in all the lights and what's going on. And the nurses will love you to bits down there. You're so cute.
So for the surgery, just to remind you what we're going to do, first thing is, let's say it's the right kidney, okay? And here, the segment going down to the bladder is very narrow here. So what we do is we remove the bad portion of it, and we will suture this portion back here. So the kidney will be able to empty.
Good.
You know? We want to make sure that the kidney will empty downward. Yeah. Okay? Okay. See you later.
Okay, thanks. It's okay, Muffin.
We'll see you in a few hours. You're going to be tired, very sleepy. Oh, you're holding on tight.
You gotta go now, honey. Give mommy a kiss.
See you later.
Give daddy a kiss.
Okay, sweetheart, come with me. Look at you, you're so happy. You're so happy. Oh, Michelle dropped me.
Visitor.
Hello.
Is this a reasonable time for me?
Sure.
Great.
Yeah, we knew you
Good.
were coming.
Okay. So, I can see even today looking at her, she's substantially worse than the last
And
time
she's
I
doing
saw her.
today, perhaps because also she's tired, she's doing a lot more to the left leaning, stretching, almost trying to stretch herself out.
Yeah, I've noticed she's come over quite a bit. So, we hope to get her pelvis level and her spine balanced and get rid of, make her sit nice and straight and restore her contour. So we start the procedure from the front. We remove the discs, that's the soft part in between the bones. And we put a small rod in place to straighten the spines. Then with you still asleep, you're put in a different position. And there's an incision from the back. And it's generally about that long. Then we put the rod in from the back. And we use wires and usually a couple of screws to hold everything in place. I'll see you downstairs just before the surgery again.
I feel it pumping into my veins.
Thanks.
We'll try to hear for, we can go more if we need to. Do you feel the kidney? Are you seeing the kidney? Is that the kidney? So this pink, nice pink area here is the kidney. This is the fat over the kidney. So what we're going to do is remove the obstructed part, literally, and then attach the two big wide open areas back together again. Okay, can I have the tenotomy scissors back?
Tired.
Besides that,
Kid, tired.
feel at peace. Did I get on?
Yes.
I do. This is as far as we can go. Okay.
So she has, what we would do is just mark out to begin with what her actual problems are in her deformity. Most of her curvature is in the lumbar spine, and we'll need to put in pedicle screws at the bottom to lock it in place because she's got no posterior elements. Right. So. Okay? And once we've got this open, we'll be able to feel inside and feel the ribs. I'm going to just cauterize that. So the spine is there somewhere. So we're going to continue around till you see the spine. And there's the spine there. We're exposing the vertebra and the discs. Then we'll start removing the discs, which are the soft tissue in between the vertebra. Okay, now I can see the disc right down there. See it way down at the base? See that soft little bulge? Usually it would open right up and we would go in and easily pull out the disc, but in her it's very, very narrow, so it's making it very difficult to get inside and remove the disc.
Maybe another half hour or so.
Okay, so we've opened the ureter, but we have to make the reattachment as wide as we can. Not so bad looking. That's pretty good. The ureter get a nice generous. 5 French feeding tube, please. That goes down with relative ease. Beautiful. Look at that.
So we're all done. Everything went very well. Great. We found exactly the area that was narrow, that was giving her kidney the problem. So that's been removed, and then we brought the two ends back together again. They came together nicely. We've also left a little plastic tube in there. It's called a stent. It goes from her kidney down through where we just worked, all the way to the bladder. And it'll stay there for about 6 to 8 weeks or so.
6 to 8 weeks.
About 6 to 8 weeks while it heals. And then we'll bring her back here. We have to put her to sleep quickly, and then we'll just go in from below into her bladder and take it out. Okay?
Okay, well, thank you very much.
Good seeing you. All right, bye-bye.
Bye.
Hallelujah. Very good.
Now you feel better?
Yeah, now I just want to see her.
This is mine today. I gave Tylenol.
Getting the painkiller in the epidural right now.
Right. It's going right through.
Look at her. She looks so little. She's so sweet.
Okay, what we're doing now is we've got the screws in all the vertebral bodies, and we're going to take a rod, and then we're going to hook it up to all the screws and see if we can't straighten out the spine. Now, what you do is you get your 3.2 drill, and then we're going to start to put some screws in.
As we just gather here in this place right now, we call upon your Holy Spirit, Lord God, to minister to our daughter as they operate on her now.
Lord, just be with our whole family. In Jesus' name, amen.
Amen. Thank you. Amen. Thank you.
So these are the x-rays before that show what she looked like when she was sitting, and this is the part that we've operated here in the lower part of the lumbar spine. Now she still has curvature above that and a little bit below that. That's what we have to do the second procedure for. So that's going to go in like that. Just push a bit more, Bill. That's it. So we're just at the stage of just have to turn these wires down and we start closing. And we're all done. Everything went fine. So we took an x-ray and everything's nicely lined up. Curve's about 25 degrees. And
So
it doesn't,
that's the best you can expect it to get. Oh, yeah. That's what you're saying.
yeah. But when you look at her, you won't notice much curvature from the back. And you'll see that hollow is much, much better. It's not perfect, but it's much, much better. Okay?
Okay, thanks, doctor.
Okay, good.
Take
See you
care.
later then. Bye-bye.
Yes, she's okay.
Yep.
Look, sweetie, there's Mom and Dad. She's complaining of a bit of pain, so we've just given her another at least started morphine infusion.
I know you do, sweetheart. You just lay like this for now.
No.
They're gonna ask the doctor. Don't worry.
How's little Lisa?
She's doing good. She's getting a little hungry now.
No, it's normal. Yeah. So after surgery, how was it when you were back home?
She was great.
Yeah, perfect. So the plan today, once she's asleep, very quick surgery. We use a small camera. We go in the bladder. You see the small catheter we left in place on the right side after the surgery. Just grab it with a small grasper. We go out and we're done. Okay, good.
Great.
Okay. See you later.
Thank you.
Bye. We're going to use a very small scope, a bit less than 3 millimeter in diameter. Bladder. Right side. There's the catheter is out. And we're done.
Oh, don't you look cute? She got her eyes open.
Hello.
Hi.
So we removed the little stent. It went very well. And we'll see you, what, September 5th?
Yes.
With the ultrasound. Okay?
Okay.
We're expecting improvement of that kidney.
Thank
Okay.
you very much.
See you. Bye-bye.
Bye. Oh, that's great, eh?
Yeah.
Wow.
That's good. She won't even know anything happened.
No. That's good. Thirsty girl. Thirsty girl.
You know what? It's not the easiest thing getting into a chair for the first time, and I'm not gonna lie to you, it'll probably feel kind of sore. But it's a step that you've got to take. Now put your arms on your chest like this. Okay? Just as much as you can. In the middle. So that she doesn't go over that. Okay. Excellent. Thank you. Okay. We're gonna take nice deep breaths. Excellent. Good girl. 3. Good for you.
The tubes.
Excellent. Look at you. You did excellent. Good.
Oh,
Great job.
you want
I'm gonna get you a portable oxygen. I'm just gonna run and grab one.
Okay, I'm just gonna take your IV out, okay? Okay, you've got lots of gauze under the tape, so you'll just feel a little tiny bit of tape pulling your skin, okay? See, just feel the tape pulling a little bit. There you go. 2, 3, out. Done. It's all done. Yes. It's all done. Wow. Hold it.
What would you prefer? Be able to pick her up like I normally would under.
No, I don't have my back.
I know where. Okay.
Hi Lisa, how are you doing? But a quick look at your kidneys, right? How about that? Alright, Are you ticklish? You are ticklish, eh? Okay. There is your kidney.
Is this Lisa?
Oh, look, there's Dr.
How you doing?
Hi, how are you?
Good to see you.
You too.
How are you?
Good.
Can I just take a look at
How are things healing up? Oh, that's great. Good. And she's eating okay? And
Yeah, she
all
likes
that?
to eat.
Good. We looked at her ultrasound, and her dilation has come down quite significantly. So basically, we'll just continue to follow her with some ultrasounds for a little while, and as long as she's doing well and not having any,
You wouldn't know.
appetite problems or fevers or infections or anything, we should be fine.
So
Okay.
far, so good.
All right. So I'll see you in about 6 months. We'll do another ultrasound in about 6 months.
Great. Thank you for everything.
4 months after surgery, Lisa has fully recovered. Lisa's kidney will continue to be assessed by ultrasound, but doctors are optimistic she will continue to do well.
Oh, what are you doing?
Ah, there we go. And this is the way you were before. And then this is your spine, which comes up and curves like that. And then you had a little bit of a tiny curve up there. And then this is the little rod that goes in the front of your spine. Yeah, it is nuts and bolts.
Oh.
And then this is the rod that goes in the back. Okay, can you bend forward for me?
Yep.
Okay. Well, you certainly healed up quite nicely.
Yeah.
Good.
So
we're okay with the legs?
Yep, they can be. And they're actually relaxing a bit. What she just needs to avoid now is twisting and turning for another 6 weeks or so. So I like sign transfers and things like that. Okay. And no sports. And only sitting in the pool.
Riding.
No horseback riding.
Oh, I really wanted to go.
Are you happy? Do you like the way you look? And are you happy with the way you're sitting?
Yes.
Okay, good.
Okay, I'll go with you.
Now that Kayla has had her surgery, she continues to grow stronger and is no longer at risk of becoming debilitated by scoliosis.
Whoa. Whoa. Yeah.
Kayla's spine is straight, and she can once again be active in her wheelchair without suffering from pain.
Uh-oh.
The following events were recorded as they happened at the Hospital for Sick Children in Toronto. In this episode of Life's Little Miracles, Peyton's brain surgery. One week ago, 9-month-old Peyton was diagnosed with hydrocephalus, a buildup of excess fluid inside the brain, which can result in permanent brain damage. The pressure is causing Peyton's head to enlarge, and she is suffering from headaches.
What have you noticed about Peyton at home?
The sides of her head is getting larger and she's becoming more irritable.
Doctors must restore the normal flow of fluid before her condition becomes debilitating.
Is this Peyton's first MRI?
Yes, it is.
Today, Peyton will have an MRI to prepare her for brain surgery.
So that's the part of the body that will be scanning today, the brain, and because it's a fairly long study, it's about 45 minutes to an hour long.
Okay.
Peyton is required to stay still during that time, and that's the purpose of having to sedate Peyton for that test today, because she's too small to be able to stay still for that period of time.
Okay.
Right now, I'm just going to have you go on the other side. I'm going to shut the lights off.
That's okay.
Oh,
Mommy's here.
I know.
You guys will go this way and I'll go this way and I'll see you in a bit. I'll take good care of her.
How much does she weigh? 10.7 kilograms.
Scans completed and everything went well. I had to give her some more sleepy medicine because she just got up just a little bit, but then she went back off to sleep. If she continues to be awake, we can send her back up to the floor.
Here we go.
Hey. Hey, you.
There we go.
Morning.
Good morning.
Peyton has hydrocephalus, and that's an enlargement of the fluid-containing spaces of her brain. And her brain is under a little bit of increased pressure. And we're concerned that if this isn't treated, that she's going to not meet her full intellectual development. And the head will continue to grow to the point where it'd be noticeable to just about anybody that it was too big. So her x-rays suggest that she has a block right in the center of her brain where the fluid comes down a very narrow passageway. And we think that that's something that likely happened shortly after birth, but we're still waiting for the final MRI results to know exactly why that's there. But
So you don't think she was born with it? Or?
we may not be able to tell.
Okay.
She's one of the few children who we think could be treated without a shunt, which is a drainage tube that goes inside the head, underneath the skin and down to the tummy, but rather by going right inside her brain with a scope and making a very small opening in the floor of her brain and bypassing that block and allowing the fluid to circulate. It's a little bit more difficult than putting in a shunt, and it has to be done very carefully because there are some very important structures at the bottom of the brain right where we make this little opening. And we have to go into the operation with the idea that we'll have a look at the floor of her brain and make sure that it's an ideal surgical situation before we proceed.
Okay.
Because we don't want anything to happen to her.
Where's Peyton? Where is she?
Okay, hi. So, do you have any questions at all, Dad? I didn't really have a chance to talk to you.
No, not really. Audrey's really kept me up to date, and it's
okay. So, we're going to make a little incision right there,
Okay.
and then that should be all right?
All right.
The rest will be done with the scope.
Will the shape of her head subside a little bit?
A little bit, but her head is always going to be a little bit relatively large.
So you said that it will be 6 weeks before we know if this works.
Yeah, it'll be done in stages. First of all, we'll just see how the operation goes today, and then we'll just see how she responds over the next couple of days.
All right.
Great, thanks.
Thanks.
Smile.
Soon it'll be all over with. All done. Right?
All right, Peyton. I'm from anesthesia, and we'll monitor everything, in terms of gas exchange, heart and lungs, and temperature and breathing and all of those things that are important.
Will she be in a lot of pain after?
I don't
Like-
think so.
No,
not
it's not a
typically.
big-
This is not a, but we will treat it. You know, I mean, we'll have something to treat her,
Yeah, but
and
it's
she'll
not
be in
a-
a monitored setting, so that it'll allow us some freedom in terms of the amount of drug we can give, and we will keep her there until we're happy that she's breathing and awake and alert, and hopefully not encounter any other complications.
Okay.
Okay.
So I'm going to take Peyton.
Okay.
Okay, I'll just take her in my arms rather than lay her on the bed.
Okay.
I'll try to keep her asleep. Okay. Okay. Yep, that's great. There we go. Okay. All right. Can you give her a kiss? Okay, sweetie. It's okay. All right, we're going to go then.
Okay, so this is the sagittal MRI, and these are the ventricles here, which are very dilated. We can't see on any images exactly why this has happened, but that's why she has the hydrocephalus. So what we're going to do is just make a tiny little opening right here, and that'll bypass this block, and then the fluid should start to circulate normally over the surface of her brain. And we can see this very critical structure here, which is the basilar artery. We have to be extraordinarily careful with that vessel. We can't injure that at all. So her soft spot is still open. So we're just going to go through the outside edge of that. And so we don't really have to drill any holes in her head either. So I've got her lined up nice and straight like this. So that helps us keep oriented from front to back, left to right. Yeah, I wouldn't go any more medial than that. That's good. Scope is fairly big, so we need to have enough of an opening that we can get it in. So we can tell her pressure's high because already her brain is starting to bulge a little bit.
It'd be better just to walk around and not think about it. 2 hours, it will seem like 2 days.
Okay, so we've tested the equipment, we're all set to go. And now we're going in with a scope sheath, and we're going to go through a very small part of her brain, and we're just going to be basically pushing the brain fibers apart. In fact, you're going to drive. So straight trajectory down the scope, eh? Absolutely straight. Don't force it, nice and easy. Don't force it. There you go. Okay, so now we're all on camera. There we go. Okay, now we're inside the brain. Okay, so we're over too far on the right side. So there we go there. So now we're going to go down through the foramen of Monroe, which is that round area there, and that's our first target. And her block is probably just about there. We're not even going to look at it because it might start some bleeding, but it'll be just about there. And there's the basilar artery beating in the base of the brain, and that's the very important artery we have to stay away from. And we go a little bit farther forward. My goodness. This could be a challenge because it's so, you know what, the floor is already so thinned out that I'm afraid of going down where we normally go because I'm too close to the artery. Okay, I'm not even going to go down that way. I think it's too dangerous to go down there. Here's the top of the basilar. Just asking for trouble. Normally what we do, we go down there, but I'm not happy doing that today, so I'm going to do something a little bit different. I'm actually going to try and make an opening there. So there's my forceps. So I'm lifting up the floor of her third ventricle there gently. It's starting to beat a little bit. You see that? So that's a good sign. There we go. There, that's better. Okay. Oh, that's excellent like that, actually. Look at that. So, yeah, see how it's starting to well up? That means that we've got a nice opening to start with. So our intracranial pressure now is quite normal, and we've got a nice opening in the floor. We just spend a little bit extra time making sure that the opening can't close over again. Okay, come on out. Lights on, please. I'll need a little piece of gel foam. Just going to close the skin. We're done. One more floor. So that's it. We're done. So everything went fine, and she's a little bit more difficult than usual because this has been there long enough that just for anatomical reasons, the floor of her third ventricle was almost like a cylinder instead of a floor.
Mm-hmm.
And we had to make the opening just a little bit farther forward than we often do, but just to make absolutely sure we stayed away from that very important basilar artery at the bottom.
Okay.
So it just took a little bit longer. And then
Will that affect the outcome at all?
I don't think so, because we persisted, and the floor of the third ventricle was like this, sheet waving in the wind once we had it decompressed.
Once the pressure was released.
Yeah, and so we spent a little bit more time and just shrank it down a little bit and opened a little bit wider, and ultimately we had quite a nice opening. But we'll just watch it very carefully and just see how things are going.
Okay.
Okay?
Mm-hmm.
Thank you very much.
Thank
Okay,
you.
You're welcome.
Just sleeping.
She is.
Oh, look at her.
Just put a little oxygen on her for a while, okay? She had a little pain medicine.
Do you think she's in much pain, or?
She was crying, she was waking up and crying, so the anesthetist decided to give her something for pain.
Great.
She may have some discomfort. She may have a little nausea.
So she'll probably be here for an hour?
Here for an hour. Yeah, she came in here at 11:30, so 12:30 if all is well and she's awake and not complaining, she'll go upstairs to her room.
Hi, good morning. How's Peyton today?
She's better.
I'm Dr. Ratka, and I'm Dr. Drake's partner. So I'm just stopping in to see how she's recovering from her surgery. Can you just have a quick feel of the top of the head here? Okay, sweet. I gather there was a little problem after the operation with what sounds like seizures, right? What I think we'll do is watch you in hospital for another day or so. An EEG will be done today to be sure that there's no active seizuring going on.
Is it time for her medicine?
So neurology came by while you were gone.
Okay.
And they said it's all negative. The EEG was negative.
Oh, good.
So that's good. So tomorrow, their plan is to keep the dilantin for today.
Okay.
And then he's going to talk to the big cheese guy, the big neurologist, and then they'll probably start to wean it off tomorrow.
Oh, excellent.
So that's good, Peyton.
Yay, that means we get to go home even sooner.
Yep. So probably today's Wednesday, maybe by Friday. Everything's okay.
All right.
Hopefully.
Her eye looks better.
That's because you're riding up in your stroller. Yeah. I think you're tired.
Yes, she is. Like this guy? looking at me. I see ya. I see
You want her up or down?
She can sit her sort of sideways. Sweetie? Hello.
That's the only thing she never cried for.
Should be used to that. Almost.
It's okay, we're going home.
It's pretty straightforward. Just special instructions. Observe incision site. They're dissolvable sutures, but just make sure that they are going, and well, you'll know if you see any redness. Follow up with Dr. Drake in 6 to 8 weeks.
Okay.
So this is just what you need to sign.
Perfect.
Take her home. And are you planning to sort of leave now?
Yeah.
Is that it? Okay.
That's all right.
Yeah.
Bye. Take care.
I think she knows we're heading home.
Yeah, I hope. Does this look familiar, Peyton? Hey? Does this all look familiar? Hi.
How are you guys?
Good, how are you?
Good. How's she doing?
She's doing good.
Hey, sweetheart. Very good. Okay. Do you want to pop her up here on that table and take a peek at her?
Sure.
Lift your sister with you, will you?
Yeah.
Oh, let's sit you up. That's a girl. There's your sister. Yeah, that's a girl.
Is she always going to have a soft spot there?
No, that should eventually heal in.
It'd be a good thing we brought Casey for keeping her occupied.
Okay, and I'm going to want to look in her eyes. So, Dad, I want you to hold her kind of on your shoulder on this one first.
This way?
Yeah, just shift her over onto the shoulder a little bit. Aren't you a good girl? Oh, aren't you a good girl? Aren't you terrific? That's wonderful. Good for you. Excellent. Great. Look here, sweetheart. Okay, great. Her pressure in her head is much lower than it was before. So what's happening with her seizures? Is that?
Nothing.
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 And was she on anticonvulsants for a short period of time?
No,
Well, she was here, and then when we took, by the time we took her home, they had taken her off of it. So.
Okay, so let's go look at her MRI. Okay. This is before the operation, and this is the scan that she had at the end of October. And initially you'd think, well, there's not really that much difference, but in fact, I think there are some quite significant differences. And if you look at the fluid on the surface of her brain, here there's very little fluid in the surface of her brain. If you look here, you see all the white fluid?
Oh, yeah.
So the fluid is circulating how it should be. It's coming out here and it's getting over the surface of her brain. There's no question that the operation has done what it's supposed to in terms of restoring the normal pathways, and I think it looks significantly better. So I think we should just continue to follow her along, make sure she continues to develop and is making good progress, and maybe get another MRI in another 6 months or so, and just see what that looks like. But I think so far so good.
And her behavior's better too. She's happier and.
She got the personality that we expect.
Okay.
Thanks for the excellent care.
Thanks for everything. Bye. Take care.
2 months after her brain surgery, Peyton has fully recovered. Now that the pressure inside her brain has been relieved, Peyton is no longer suffering from painful headaches. She will return to hospital for checkups, but doctors are optimistic that damage to her brain has been minimized and that Peyton will continue to do well. The following events were recorded as they happened at the Hospital for Sick Children in Toronto. In this episode of Life's Little Miracles, Jamie's palate surgery and Daniel's club feet repair. Nine-month-old Daniel was born with club feet, a condition caused by tight and shortened tendons. As a result, his bones are in the wrong position and his feet turn inward and down.
And is it both feet or just the one? Both feet.
Daniel must undergo surgery to correct the position of his feet, or he will never be able to walk. Today he will be fitted with a final set of casts that will stretch his tendons in preparation for surgery.
How are you? Good. Hi. How are you doing? So what we're going to do is put on some casts today and then take them off just before the surgery.
All right.
Okay? Good. And what I do in the surgery is I take the joints, which are out of position, and I put them back in the correct position. And then I'll use a pin, usually one pin, to hold everything in place. Okay? Be a month after the original surgery. The cast comes off, the pins come out, and then he gets fitted for these little plastic splints, which he'll wear for about 6 months. And then he'll come out of those and go back into regular shoes.
Will he have trouble running, like to play baseball or anything like that, or?
Probably not. He will tend to in-toe a little bit, and that may cause him to be a little more awkward than, say, other kids of his age. We generally don't find the club foot holds him back too much.
Okay. You remember these things? You had them ever since you were born.
Okay, let's make this thing work.
13-year-old Jamie was born with a cleft palate and previously underwent surgery to repair it.
Okay.
The surgery was successful, but Jamie's palate is still not fully functional. Too much air escapes through Jamie's nose, leaving her with hypernasal speech.
So the first thing I'd like you to do is just to count for me from 60 to 70.
60, 61, 62, 63.
Jamie has decided to undergo an additional surgery in the hope her voice will be normal.
69, 70.
Okay, very good.
Today her speech will be evaluated in preparation for the surgery.
So what we're going to do today is listen to your talking, and we'll also do some talking on the computer so that we can get some measurements of how much sound is coming out through your nose and how much sound is coming out through your mouth. Okay? And what I'm going to do is I'm going to give you this to wear, and you can see that there's 2 microphones. And I'm going to have you read some sentences now.
A school day for Susie. Susie eats cereal or toast for breakfast. After that, she rides the bus to school. Susie likes to sit with Sally. At school, the teacher gives Susie's class a test.
Good. Okay, let's take this off. All right. So what we were able to see on the computer test is that it confirms that Jamie is getting a lot of sound coming through her nose when she's talking. Typically what we would see is when the sounds are coming out through the mouth, the dots would be low down, and in Jamie's case the dots tend to be higher up. What we would like to do is to see Jamie back here again about 6 to 8 weeks after surgery and be able to see if there's a difference.
Okay.
All right?
All right.
All set?
Thanks.
How's it going?
Good.
Good. Hi, buddy. How are you? So we're going to operate on both feet today.
So you're just going to be straightening his legs for now and putting him in casts up to his hips. That's what I understand. There's going to be pins in there
Yeah,
holding
so
it.
I'm gonna take the bones which are out of position, I'm gonna put them in the correct position. And I'm gonna lengthen the tendons. Tendons are the way muscles insert into bones, so I'll lengthen the tendons, and then I'll use pins to hold the bones in the correct position. And those pins stay in for about a month.
A month.
Yeah. And I'll come out and see you in the surgical waiting room and see you then.
Come on. See the nurse. Come on, sweetie. Oh, you're so cute. Yes, you are. Oh. Okay, say bye, Mom. Oh, you got the hair. Bye, Daniel. Daniel. Go.
What I do is tend just a little bit proximal to that crease. I'm heading about halfway between the tip of the fibula and the sole of the foot. Find the tendon there. Scissors, please. Now what you need to be doing is pulling with this retractor this way, because that brings the foot towards me. There. I need to release that. And watch out you don't head this way, because you'll catch the vein. So now I've released all the way around. You can see that's the way the foot used to be.
Yeah.
And this is the way we're going to make it. And see how the effect that has on the foot? Sometimes they're really loose and sometimes they're really tight. I would say that's moderately flexible. Okay, get your gun. Annie. It's right there.
Good.
Okay, just back it up a little bit. Okay, good.
All right. The reason we're doing this operation is because your speech is hypernasal. And the reason it's hypernasal is because she has a history of a cleft palate. And the palate repair went well. There were no problems with that. But her palate's a little short, a little scarred. And you need an effective movement of the palate so that when we speak, air is directed out the mouth and not out the nose. In Jamie's case, that mechanism isn't working perfectly, so some of the air gets directed out the nose. So what we're doing is we're going to raise a rectangular flap of tissue from the back of the pharynx, and we're going to bring it up and attach it to the back of the soft palate like that. And so what we're trying to do is reduce the amount of air that comes out the nose so she has less hypernasality. All right.
Okay, Jamie, we're ready to go. Okay. Do you want me to walk you to the door? Okay. All right.
Okay, Jamie. Okay. Okay. All right, good luck. Okay, I'll be here when you get out, okay? Okay?
So
I'll see you soon. That'll be okay, that's pretty good.
Okay.
Okay. So,
Okay, we'll see you later.
It's the worst.
You guys want to have a look at these? The pin on the left side's a little bit better than the pin on the right. See how it's in line with the talus?
Yeah.
And the cuboid now is nicely reduced on the calcaneus. So that looks good. We've corrected the foot now. We're just stretching out the medial soft tissues.
Will you wait till after to
No, I'll go talk to him now. All done. Everything went exactly as planned. The bones which were out of place, I put them back in the correct place. And then I use a pin to hold everything in place. Okay?
So he's got the cast right up to his
Yeah, right up to here. And they come down to just about his toes. Okay? And you'll see the foot is pointing down and turned out to the side. So when you look at it, you'll see, wow, it's really kind of a funny position. But that's deliberate. Because, of course, it was in before we started, and now I turn it out a long way, and then in the end it'll end up kind of halfway in between. And
Does he have to sleep on his back?
No.
Or whatever position he wants?
now whatever he wants. He'll do a lot of flipping all over tonight.
Yeah.
Sometimes the first night's so-so, and sometimes it's not so good. So those are your two choices. So-so and not so good. But they'll give you pain medications, and hopefully that'll keep him relatively comfortable, and he'll feel a lot better tomorrow.
Hello. How are you? Good.
Yeah, morning. Yeah.
Listen, the anesthetist said she gave him medication just after the surgery. See his chest and stuff? Sure. Just a little bit elevated. His foot is nice and pink and warm, so he's okay.
Sweetie. Oh, you just want to sleep.
And the forceps. So we'll be taking our rectangular flap of tissue from the back of the throat here, and I'm going to mark out the flap with a marking pen. Alrighty. Scalpel. Great. Super. So this is what we call a superiorly based pharyngeal flap. We've raised it from the back of the throat, and this flap is then going to be transferred up and attached to the upper side of the back of the soft palate. Okay, can I have that suture? Pillar retraction?
When will leave the trumpet in?
Just till the next day. It's really just to form an access for suction. Okay. And then with these, if you tie the knot on the inside of the tube, then you don't have to hurt them to get it out. Have some irrigation and suction, and that's it. We're done. Everything went really smoothly.
So it looks like it's the way that you want it and everything?
Oh, it went together exactly the way I planned, and we'll just wait and see whether that works out the way we wanted it to.
Okay.
It's going to really be several weeks before we really know how things went.
Okay. Okay. It's over. That's the main thing, right?
How is everybody today? We're excited. You're welcome, Stephen. I guess I'm still here.
I'm Faye. Just to sort of go over probably the same things that they went over during all the cereal casting. You want to make sure his toes are nice and warm and pink. If you start noticing any discoloration that's seeping up through the cast, and especially if there's a bit of a smell, I want you to call us as soon as possible. And that's it.
Okay.
Okay? Thanks.
Bye.
Bye.
Hey there. How was your night?
Alright.
Not too bad? How you guys? Okay, so we're just going to take that trumpet out. No big deal. Alright, shouldn't hurt you. And your head back. One stitch to cut. Alright. So just take a big deep breath in. And out.
Oh.
Great.
How much of the swelling's gone down by now?
Oh, it's still going on for another day or two.
Another day or two?
And it takes about a week or so after that to settle down. As soon as she's comfortable and drinking well, she can go home.
Okay.
Maybe as early as tomorrow she'd be able to go.
Wow.
So it's going to be a little while before we sort of know where we are as far as the speech is concerned. Okay.
Thanks very much.
Thanks a lot.
Alrighty.
Thank you.
Okay, sweetheart.
So the plan today is to take his cast off. We're going to take the pins out. The pins are about the size of a darning needle, and they just slide right out. Here you go, big guy. And so, Mom and Grandma, you're really going to have to hold him.
There, the noise is gone. Okay.
Okay.
All right.
I know. All right, now, Mom, I'm going to take this off, and I just want you to hold him underneath his thigh. There we go. Look how straight those feet are. are. These are good feet. Yes, these are good feet. Let's lift them up for a second.
Mommy's not watching.
Don't
I
watch.
can't watch either. I expect you not to watch either, baby.
Here we go.
No, no, Mama.
We're just going to hold that for a minute.
See, all done. All done.
There you go. Done.
One more set of cast. That's all, buddy. No splints.
Today's the day you get your life back. That's for me. Here you go. Won't hurt, Daniel. Stay still. Beautiful. There's the end of the incision. That stitch will just fall off in the bathtub. So I'm going to send you upstairs to orthotics now. And you're to wear the braces. I believe he said 23 hours out of the day. So the braces are to keep the feet up in the corrected position.
Okay, here are the braces for you. Yes. I know. It's a little bit sensitive.
It's
Yeah.
not gonna do nothing.
So you have to put the narrowest angle here and then slip it down. Try to bend the knee a little bit and push down the heel. You have to draw the toe a little bit. Then fold it up and put the toe strap on. Okay, all done. We might stand on the floor and let me have a look. Can you? Just stand on the floor.
Stand up.
Yep, stand up. Yeah. And now and then you may have to exercise the ankle a little bit. Okay, all done.
Bye.
Shake hand. Oh, good boy. You can shake hand with me.
Bye-bye.
We're back again.
How have you been the last, 6 weeks, right?
Yep.
Yeah. Great.
Yesterday.
What about her voice? What do you think?
It sounds pretty good. She wanted to put her message on the answering machine. She did, and everybody keeps calling saying, "Who's that kid that's answering? Who's on the answering machine?" So they don't recognize.
That's what most people notice. I mean, it's harder for you to notice.
Yeah.
Because you're always with her and stuff. That's we hear that all the time. Let me hear you say some things for me. Ba ba ba.
Ba ba ba.
Baby baby baby.
Baby, baby, baby.
Excellent. So we'll probably see some improvement still over the next 6 months or so. She's sort of got to learn how to use the flap. Would you go through it again?
I would say yes, other than the fact that it hurt.
I'll ask you the same question in 6 months, and you'll have forgotten about the pain by then. So that's great. You've done great. So I'll see you.
Okay.
Great.
So how was school today? Anything special?
Yeah, we had an assembly.
So was it interesting? Did you get anything out of it?
Yeah.
2 months after surgery, Jamie has completely recovered.
That was in the morning during French.
Her speech is less nasal, and Jamie looks forward to continued improvement as she adapts to her repaired palate.
7 miles.
Hi, how are you? He's not looking like a baby anymore? No. And is he walking?
He's walking around furniture behind his toys and stuff.
Right, so he's not kind of walking independently yet?
No.
Okay, can I have a look at his feet? Yeah.
Oh.
Oh, I'm sorry. Here we go. Well, we get him to come down, and that's pretty good. And then we go up. And that's pretty good. So his motions, he fights me, but it's quite nice and flexible, and the feet are shaped exactly the way I would like them to look. I mean, you don't need to wear the braces anymore. Go for a walk. Yeah, show us what you can do.
He's pretty tentative still, isn't he?
Yeah. Daniel's surgery has been a success.
He's happy to be out of his braces. You're looking good.
Doctors will continue to follow Daniel's progress as he embarks on his next step of learning to walk on his own. The following events were recorded as they happened at the Hospital for Sick Children in Toronto. In this episode of Life's Little Miracles, Andrew's eye surgery and Gregory's kidney operation. Six-month-old Gregory has been diagnosed with hydronephrosis, a painful condition in which urine becomes blocked inside his kidney.
Let's put him on the bed and we'll get him undressed. I'll take his temperature.
As a result, Gregory's kidney function is deteriorating, which could lead to poor physical and mental development. Today, Gregory will undergo surgery to clear the blockage in an attempt to restore his kidney function before irreversible damage is done.
Hello. How are you? I'm Dr. McClory. Why don't you just tell me what took you, this little guy, to see Dr. Cormode in Huntsville, okay?
Gregory was screaming a lot. He was crying all the time, and his scream had changed to sounded painful, so we took him to my doctor, and he suggested an ultrasound. So he had an ultrasound, and they found it just by chance. Now we're here.
The kidney is swollen up and appears to be blocked. I'll tell you what our understanding is from all these tests is that the tube from the kidney has formed in the manner of having a kink or a twist in it, or we know that sometimes the muscle just doesn't develop.
Yes.
And that what we do is we actually take a small piece of that tube out and then put the tube back together again, so it's not blocked. I would anticipate that we generally leave a small stent or tube inside the kidney. It just ensures that everything's lined up when we put it there, and then we take that out in the clinic. Okay.
Thank you.
8 months ago, 9-year-old Andrew suffered an injury to his right eye.
So I'm going to put your eye drops in.
Scarring on his retina has left him with severely impaired vision.
So just look up.
Today, Andrew will undergo surgery to remove the scar.
Okay, ready?
The operation could result in retinal detachment, causing blindness, but it is Andrew's last hope for improved vision.
Okay. Yeah. So this was an injury to your eye. I see. What happened?
We were taking like sticks and poles and bashing it up, and cousin Spencer swung it around and smacked me right smack dab in the middle.
Your eye?
Yeah.
With a stick?
A pipe.
A pipe.
Pole.
Okay. Your eyesight, are you able to see out of your right eye?
Yeah, when I want to look at something with my right eye, I have to look off to the side. Because I don't have my center vision. I just have
peripheral.
The.
So, do you have any other questions?
No.
Okay.
So you all set?
Yep.
Okay. You know what happened to Andrew's right eye was with the injury, with the blunt trauma, he has a break in the choroid. After that break, he has formed a very thick scar. And unfortunately, that scar is sitting right in the middle of the center part of his vision. So with that, he really see poorly. And the surgery is an attempt to remove that scar. Any surgery has some risk, and The real risk that I'm concerned is retinal detachment.
Right.
That can happen in about 10% of the cases. But the hardest part is after the surgery. You have to keep it face down for
Yes.
a good 10 days to 2 weeks.
Yes.
And so that's the only thing that really is
That's
hard.
gonna be the
yeah,
hard part.
that's right. It's more work after the surgery than actually at the surgery, at the time of the surgery.
So what do you think? You all right with all that? Yeah? Do you have any questions or concerned about anything? You're good?
Nervous?
Yeah.
Yeah, it's normal. Okay, all right. So I'll see you inside. Okay.
Okay, thank you.
Much.
I'm Dr. Kemp Anesthesia, and this is Gregory, is that correct? Yes. Yeah. For the anesthetic, I should tell you, we'll give him a mask of laughing gas, render him a bit senseless, and we get him off to sleep, and so he doesn't have to be uncomfortable.
Right.
Usually put the laughing gas on, make it smell like bubble gum or something pleasant, sing him a song, and then he's off to sleep.
Any more questions?
No, I don't.
Right, love? Come. Wanna take this one? Yeah. You wanna take this one, little munchkin? There you go. Okay. All set?
He will take good care of your baby.
We're operating in the space between the rib and the hip area, and this is a space that doesn't have muscles in it. The kidney is well protected within the rib cage, and as we've seen the large dilated stretched out part of the kidney and the collecting system, we're now going to, I'm now looking at the normal ureter, bulging kidney there, and the normal kidney right here. And what we will do is we will take out this section of blocked junction, which hasn't quite formed right, and we will sew it together in a manner that's more funnel shaped and open.
Hello, Andrew.
Hi.
How you doing?
Good.
Good. Somebody bonked you, did they? What happened?
Well, I was at my dad's one weekend in October. We found a whole whack of old lawn chairs, and so we were smashing it up with pipes and sticks, and then all of a sudden we're having fun, then just then it hits me, and then I was screaming like...
I'll bet you were.
Yeah.
Well, I guess we're gonna help you get better.
Yeah.
Very good. All right. Well, I'm just gonna go set up the room,
Okay.
and we'll take you in a few minutes, okay?
Hi.
You okay?
Yeah. My stomach's turning.
Is it kind of trembling? Butterflies in there. Yeah, that's okay.
I can have like a taste of but
Hey, buddy. See you tomorrow.
let's go through here.
We're now inside the kidney there, and there's the area we're going to take out right there. I will go across. 5-O-proline, please. But this is a small stent. It helps align the area of the repair in these very fine tissues. And one end of the tube will stay in the kidney, the other will go down the area of the repair. And that stent will help the kidney drain during its healing process. Take it like that. We're all done. He's fine. I have left the small stent in there, which acts as a stabilizer over the first healing days.
Right.
Then we'll have you home and have you come back. Taking that little stent out is sometimes babies pull them out. We've done everything we can to stop that happening, but we'll teach you how to take care of that. And okay.
Fantastic. Thank you. I want to see him now.
Those things you can't see, right?
Oh,
okay.
Just raise
You're all right.
Just sit on the corner, please. Can you get the light pipe ready, please?
Yeah. Add light.
So you can see the scar right in the middle there. Yeah, this is all the way. Yeah. Do you have the subretinal instrument ready? Okay. So let's try it. We're going to inject through the retinopathy site. See the detachment created? Yeah. That's right. If you inject too fast, the jet solution will blow a hole in the retina. Inject again. One of the worries is that when you take out the scar, you take out all the RPE with it, but it looks like there's still healthy RPE underneath it. So, and the scar just come away on its own specimen. So we're going to take out the fluid inside the eye. We'll do a complete air-free exchange. Yeah? Because it's going to be a complete field, meaning that the whole eye is replaced with the gas. Fill the eye again. It's better? Okay, 6-point inject. You're down to 20, let me know. So I will start tying up the superior port. It's a little light. Just one more injection will be fine.
10.3.
Yeah, I will be fine. Yeah. Okay. That's it. Hi. Everything went quite well, actually, and we were able to isolate the scar and remove it in a single piece. And
Wonderful.
overnight, he will have to start keeping his face down positions.
Right.
But shouldn't be too bad because the surgery only requires small incision to the eye, so the eye shouldn't be too uncomfortable. But that's it. You all right?
The nurse wait. 100 months here, honey.
Sweetie. Hi, sweetheart. How are you feeling? Feeling alright?
He just had a little touch of morphine. He was a little bit in pain, so a small amount, but he's getting a little bit better.
That's good. You tired? Yeah? Yeah. You go to sleep, okay? Yeah?
Hi. How are you guys doing? Greatly. Hi. Yay! I got that big smile again. That's good. Well, we can take the tube out. Okay.
Cool.
Let's go do that. Yeah. Okay, so I just have to cut those little stitches, and out it comes. Yeah, that's a good boy. Yeah. Okay, 1, 2. One more. Ouchie!
Oh, that didn't
Ouch,
feel
that
good.
wasn't very nice.
No.
That was a mean one, wasn't it? Yeah, that was a mean one. Okay, all done. All done. What are you doing? You cried more for the stitch. All the urine will bypass down now to his bladder.
So there won't be any more pain for him or anything?
You shouldn't
because
have
this
any
is out?
discomfort at all now that this is out, yeah.
Andrew, put your head down.
Okay. Put your head down.
Put your head down, please.
Put your head down.
Here, and then like going back.
So I had to be there while they came.
Put your head down, Andrew, please.
Whoops.
No, not just your eyes go down. Your actual chin needs to go down here.
Morning. Hi.
We want you to tell him the importance of keeping his head down.
It's hard, I understand.
Yeah, it's
because,
been terrible.
look at me. Great. Can you see the shadow from the gas bubble now?
I can see a big black line just arching right over.
Is it in the middle or in the bottom?
I'd say higher than the middle, not the top.
Okay.
But
I still need you to keep your head down for a little longer. So by keeping your head down like this, then the gas bubble will move away from the lens. Because right now, in this part here, on the back surface here, there's a little bit of changes from the gas touching it. You start to have a little bit of a smudge on the lens now, and that probably will clear. But if you don't get that gas bubble away from this back surface, then it's going to get thicker or more cloudy, and then you're going to see less because of that cloudiness of the lens.
You had surgery June the 22nd, is
Yes.
that correct? Yeah. Good. And how are any problems?
not really.
How's your vision?
The top half's pretty good, but there's a shadow of the bubble. At the bottom of the shadow, I can't really see that much.
Okay. Let me check your vision. Okay, so cover your left eye. Just look straight ahead for me. Into that. Do you see that letter up there?
E.
Keep going. Try really, really hard.
All the other ones are just little black dots.
Can you see the letter beside the E?
No.
Okay, you're right there.
Yeah.
Your eyes watering.
What's he doing? What's he doing?
I might just get you to undo one tab for me.
Oh.
I don't even need a TV.
Hi, how are you? He's looks happy to me here. So overall, I have I've taken the opportunity of actually looking at his ultrasounds before I saw you, and they're much improved. And I would suggest that he's now pretty well on the path that I would expect after an operation like this.
Right.
He's in the normal post-operative state now of a kidney that's fixed that I think will stay fixed and working with him for a long, long time. So get him on to being interested in jumping around, getting into all the trouble that
He's working on it.
Yeah, what's that? Yeah. Ooh. Yeah.
Now that Gregory has had his surgery, he no longer suffers from the pain of a blocked kidney. Gregory has good kidney function, and he shows all the signs of normal physical and mental development.
Now, when you look at things now, I remember you told me that before we had the surgery, the center of it was quite unclear. Is it still like that, or is it has it changed anyway?
A little.
A little?
The blur is getting a little smaller.
Smaller? Yeah. As far as the surgery and the aftercare, everything seems to be fine. Like, he's healing nicely. He didn't develop any complication related to the surgery. He was good in position afterwards, and that clear. So there is no residual changes related to it.
The cataract that was starting to develop, has that
That's disappeared.
Oh, has it?
Yeah, which is good. Yeah, I agree.
Excellent.
Yeah.
Good. That's good.
Yeah.
You knew it wasn't going to be 100% right away. So that's good.
You have to do that. Keep your eye on the ball. And keep your eye on the other corner, too. Good one.
5 months after surgery, Andrew's eye continues to heal.
You want to try?
Although his vision has not been entirely restored, Andrew can now see better and can look forward to improvement with time. The following events were recorded as they happened at the Hospital for Sick Children in Toronto. In this episode of Life's Little Miracles, Daniel's cranial reconstruction. "13-month-old Daniel Daly was born with Apert syndrome, resulting in the premature fusing of the bones in his skull.
There he is. Up we go. There we go. Just gonna measure your head. Alrighty.
His skull must be reconstructed to allow his brain enough room to grow, or Daniel could face permanent brain damage.
Yeah, that's the guy.
The syndrome has also caused Daniel to suffer from hydrocephalus, a condition in which the normal flow of fluid inside his brain has become blocked. Today, doctors will attempt to control his hydrocephalus by inserting a shunt to relieve the buildup of fluid in his brain.
About 30% of the kids with APERTs overall end up needing a shunt. So we're going to put the shunt in, and we'll probably put it in right up here. And because of his head shape, we're going to use ultrasound guidance to make sure we get it in the right place. And the whole system will be underneath the skin, and then we'll tunnel it down here and make a little tiny opening in his tummy and put it in there.
Does it go right in the stomach, or?
No, it goes into the cavity that contains the stomach, but it's outside all the organs. And the fluid is absorbed back into his bloodstream and then recirculates normally. And then the only issues afterwards are, as I mentioned, the shunts tend to fail with time. And the highest time for them to, or the most common time for them to fail is within 6 months of surgery.
Oh, okay.
Okay. So we'll follow them very closely for the first 6 months.
Okay.
Hopefully the shunt will address the CSF flow problems even after his craniofacial surgery. Okay.
Shamina gets booked for 2 hours.
That's just kind of on average. Could be a little longer, a little shorter, and that's not all operating time. That is getting him to sleep.
Yeah.
So, do you have any questions?
If I don't know if you have to shave their head for the incision, the doctor, and if
Yeah,
he does,
well,
I want
Save
it
some of the little curly straws,
Yeah.
not a problem. Put them in
That's
a little
all
bag and put his
that'd be
name on
great.
it. Those little curls are precious. Yeah. Okay. You have a big smile now.
Okay.
Okay, we'll take good care of him. Yeah. We're gonna have a little break for a bit. Oh, don't be too sad.
We knew this was gonna happen.
No one can replace Mom, but we'll sure take good care of you, big guy. Okay.
See you later, buddies.
Okay, we'll look after him. Okay. Here we go. The open sesame. Mom wants it to save the hair.
So we've assembled 2 teams of surgeons to do this operation as fast as possible. One team is going to work on the head, and the other team is going to make a small opening in his abdomen. We're going to use 15 blades, okay? He's just a baby. Okay, the drill. Just make a small opening in his skull, and we'll make it a little bit bigger today so that we can use the ultrasound. Great, okay. So this is what we use to pass the shunt underneath the skin. And so we're going to just tunnel underneath the skin very gently. And the shunt now. So now we're going to pass the shunt down the first stage. That's the first stage, nice. Now we're going to pass the second stage. Okay, so now we've tunneled the shunt from the incision in his abdomen up to the back of the scalp. And can I have the ventricular catheter? And now this is where I'm going to place it using ultrasound. So there I am on the screen, you see that? And there I'm in. All the holes are in, and it's in perfect position. So we've just attached the valve onto the ventricular catheter.
Can I have that closer?
This is the hardest thing in the whole case right here. Okay, that's just perfect. Good, good. Okay, you just close it up. Okay. Good.
Which side is it down? Right side. To the front. You'll be able to see anything now when you're dressing. It's okay. It's okay. That should be touched.
Morning. So it's been a little while since I saw you guys. How did the shunt go?
Good, really good.
So basically, the purpose of the surgery today is to reshape Daniel's skull. As we've talked about, the nature of this operation is with an incision that goes from one side of the head across the other to expose where the abnormal shaped skull is, and then to remove it, reshape it, but also to give the brain more space to grow and develop, and also give the forehead a better contour and more space for the eyes to develop. So I think we'll be doing the back first, and then we'll do the front.
And that, how do you do the back? You just take it off and reshape
It's
it?
the very same technique. Yeah, we use the same incision, and in order to do the back, what we have to do is we have to put him on his tummy when we do the back, and then after we've done the back, we'll turn him over and we'll do the front. The fact that the shunt is there may limit exactly what I'm able to do somewhat, because if we affect that shunt's function, it can also have detrimental effects on Daniel. So this is going to be a long day for you guys.
That's what we're prepared for.
Okay.
You need to better being carried?
Hi, Dana. Okay, let's come on. Let's go. Hi there. That's all right. Let's just take this with us. Yeah.
It's she got on her head, eh?
Yeah. Do I look funny? Nice and warm. Nice and warm for you.
Bye-bye.
This is very severe. You can see the shortening of the skull from front to back. You can see that the back of the head is quite flat. The forehead is very flat. And it's hard to see, but the eyes are very, very shallow. And the cranial base, I mean, the cranial base here is almost vertical. Are we ready to go? Everybody happy? Antibiotics on board? Blood in the room? Perfect. I think on your side, Jocelyn, we're going to have to dissect all the way down and get this free, because otherwise as we lift this flap up, if it's still tethered here, it's going to be a problem. So yeah, we need to get full mobility of that. Okay, let the great Dr. Drake enter into the operating field.
So the thing we really worry about are the major venous channels, which are running like this and across the bottom here. And we absolutely have to leave them undisturbed.
So is there any way you can tell where they are from the outside surface of the skull, Jim?
Well, we know that they follow the sutures here. Right. It's a little bit unpredictable, but it's...
Yeah. Somewhere in the general area.
Yeah. Okay.
That's irrigation. Dr. Drake is doing a superb job of removing the bone, which is going to allow us to do the reshaping of the skull at the back. And then after we've got the bone off, what we'll do is we'll reconstruct the back of the skull and then get ready to turn the patient a little bit later on in the procedure. But we've encountered some bleeding. We just lost a bit.
A large piece of gel foam. Another piece. Okay, just put a patch right on top of it. You ready to go? Let's just look at everything else first. That's it. Just a little,
tiny little things.
no way to guard against those. Is he okay? Stable?
That's usually a good sign. You know, we haven't lost very much, really. It's about 100 cc's of blood.
It's not bad, actually. Okay. All right, well, we now have the bleeding totally under control.
All right. So the difficult part of this operation is now done.
Like the grunt work is done. Now the
scary
artiste
part.
part.
Yeah, right. Great, thanks, guys. Whew. Malleable, please. Medium size. That's good. Large periosteum. So what we've done is we've taken off the anterior portion of the skull, which was in this position, and we've decided that the curve here would be very suitable to reconstruct the back portion of the skull. And what we're doing now is we're going to fix this in position, and the aim is to make a prominence at the back that looks more normal, and then decrease the vertical height of the skull and narrow the sides. As we do this, you can see that the brain expands towards the back and accommodates what the new shape is going to be. So this brain is very versatile, and we're hoping that it will allow us to shape the skull lower, narrower, and longer.
Perfect. One plate here. 4 screws, 4 screws. So 1, 2, 3, 4, and then 1, 2, 3, 4. Thank you, ma'am. Was fine. So now that we've reconstructed the skull, we're just doing some minor finishing touches to the soft tissues. Now we're going to be closing the skin. So we're pretty much done, the major component of the operation. And then Dr. DeRuiter will reverse the anesthetic and hopefully wake this patient uneventfully. Wire cutter, please. What do you put? Maybe you might need some towel clips or a couple of stay stitches on here. It looks like it is going to reach here. Okay, good. Great, thanks guys. It's been a long day for you, huh?
Yes, it's finally over.
Just finished. He's awake and crying, which is a good sign. Moving all 4 limbs, which is also a good sign. Everything went very, very well during the surgery. When we did the back of the head, there were 2 very small veins that we encountered that ended up bleeding a fair bit. The nature of this operation is such that we can run into quite a significant amount of blood loss. So he lost a fair bit of blood. He got the 2 units that you donated, but he also got an additional 4 units.
Oh my God.
So otherwise, I was very pleased with the way things went. We were very careful around the shunt, and there was a piece of bone that we left the shunt attached to that we've attached to everything else. And I think he looks great. I was really pleased with the improvement of the head shape. We've got a nice round head at the back.
Nice.
I think we've got a good prominent forehead. And when you see him, you might think that's maybe a little too prominent, but I've done that somewhat on purpose because as he grows, he'll grow into it. All right.
Thanks.
I'll see you guys tomorrow.
All right.
Half an hour.
It's easy.
You okay? Yeah, I'm okay. That's what I feel.
We just want to talk to him or wait him up or touch him. Okay, how
It does look different already.
Oh my gosh. Just he's a little bit light. We don't want him to cry.
I can't believe the difference. Unbelievable, eh? Is his oxygen level low or is this for something else?
That's normal to be in the hood.
Okay.
The long anesthetic, so we need a little extra humidity.
He's doing okay though?
Yeah.
I just can't believe the difference.
That's great.
Wow.
So he's going to be here till 9. I'll take him over to ICU.
Okay.
So you're going to stay and see him over to the ICU?
Oh, I'm here 24/7.
Hi, Daniel. How you doing? Having a good breakfast? So, we talked about this as part of the whole scenario, but Daniel had a temperature last night, and we need to investigate that temperature. And as you know, we should get a chest x-ray because he sounds like his breathing's a little bit on the noisy side, and we worry when we do an operation that's fairly long that they can end up with some problems with their breathing. So he's going to go for chest x-ray this morning. And he'll also have some routine blood work. I checked his blood work from last night. His white count is elevated, and that can be just as a reaction from the surgery. But it also can be related to infection, so I think we need to get on that.
Okay, that one's done.
Good morning, Daniel. How are you today? Hi there. As far as we can tell, we can't find a source for the temperature, and the thing that we would worry about is an infection. And there appears to be nothing to suggest that there is an infection going on. And we do see temperatures when we do this type of surgery quite frequently. How's he doing from your point of view?
I think he's good. He's still pretty testy, but that's really it. He's back to eating and everything else, so.
And don't be afraid of getting the incision line wet.
Oh, I bathed him yesterday.
Great.
So, didn't like it too much, but.
Yeah.
Okay.
As I said, call me if there's a concern.
Yeah.
Okay, Daniel, you get to go home today.
Say yay. Yay.
All right.
Say hooray. Hooray.
You guys are free. Hello. Daniel.
Say
How you doing? Do you remember me? You do remember me, don't you?
Up. You're going to come say hello?
You are so sweet. When we look critically at it, we see that Daniel's head now is shaped a lot rounder at the back, and the forehead looks less prominent in the areas that it shouldn't be prominent, and more prominent in the areas above the eyes where it should be. And this will hopefully be the last operation that Daniel requires on the top of his head. When we looked at the CT scans, you can see a very nice change. That was now, I guess, about 2 months ago. Unfortunately, with Apert, with the presence of a shunt, but also the natural history of Apert syndrome, is that a lot of children do end up having to have repeat surgery because of this tendency for the bone to relapse or to return to where it came from. At some point in time, he will likely require an operation to move the upper jaw forward, and we would often do that around 5 to 7 years of age. So our plan then is to keep a very close eye on you and Daniel, and we will see you back on a yearly basis. We will schedule a CAT scan for a year from now, from the time of his surgery, just to check on things. And we'll continue to follow him with regards to his development and his facial structure, his teeth, his breathing, everything, all aspects of him.
Can you say bye-byes?
Say goodbye.
Now that Daniel's hydrocephalus is being controlled and his skull has been reconstructed, Daniel's brain can develop normally, and he is no longer in imminent danger of brain damage.
Say goodbye. Excellent. It's nice to see you again.
Thanks.
See you in January.
Okay. You want to go for a walk?
Although Daniel will face additional surgery in the future, the first phase of his struggle with Apert syndrome has been a success. The following events were recorded as they happened at the Hospital for Sick Children in Toronto. In this episode of Life's Little Miracles, Todd's splenectomy and Taylor's nerve injury. Five-month-old Taylor suffered nerve damage at birth and has severely limited movement in her left arm and hand.
There we go. Stick her under the leg.
Doctors hope to restore movement to Taylor's arm by harvesting healthy nerves from her legs and grafting them to nerves in her shoulder.
What's all this?
Today, Taylor will undergo a myelogram that will help doctors prepare for surgery.
Perfect. There you go.
So the laughing gas will make her quite sleepy and
calm her down. It won't do much for you.
Take good care of her, Mom.
And I'll give you a walk out to the waiting room.
Thanks, Carrie.
No problem.
That's the bottom slice, right?
Yeah.
Okay, let's look from the top end again. Okay.
Oh, come here. Oh, come here. Okay. I know.
16-year-old Todd has ITP, a bleeding disorder caused by dangerously low platelet levels in his blood. As a result, a simple injury could put him at risk of severe internal bleeding.
And do you bruise a lot?
Yeah. Easily.
Although the cause of Todd's disorder is unknown, doctors do know that Todd's spleen creates an antibody that destroys healthy platelets.
Again?
Today, Todd will undergo laparoscopic surgery to remove his spleen in an effort to reduce the risk of normal everyday activity.
You were outside in the summer, weren't you?
Yes.
What did Dr. Langer tell you about the operation?
He said that he like explained how he was gonna do it and stuff like that.
Okay. And what did he tell you he was going to do?
He's gonna take out my spleen.
Yeah, I know, but how?
Laparoscopically.
Okay. All right, so they'll talk to you, and when they're ready, they take you in the room, they tell you everything they're going to do, you ask all the questions you like, okay?
They drug me and
Okay, and goes the needle, 99, 98, you're
Bye-bye.
sleeping, okay? Next time you wake up, the operation's all over, okay? You're in the recovery room.
I'm not gonna like wake up in the middle, am I?
No, no. And you ask the anesthetist that question if that's a concern of yours. A lot of
it's
kids
not.
ask that question.
Here's your next
Good morning, Dr. Langer.
How are you?
Good, how are you?
So we're going to be making a little incision in your belly button.
Right.
And there'll be 3 other ones. One here, and one out here. And put a scope in there so we'll be able to see. And then we'll use the instruments that we put through the little ones to disconnect your spleen. And then we're going to put the bag into the abdomen, put the spleen into the bag, bring the bag out through your belly button and break it up into little tiny pieces. So I'll come and talk to you afterwards in the waiting room.
Okay.
And it usually takes about 2 hours or so.
Okay.
See you later.
Now, should I write down here, do you have any toys that you
I
brought
don't
with you
have
today?
toys.
You didn't bring a
You
big...
brought us
You
slippers.
just brought the fluffy slippers. I gotta write down the fluffy slippers.
Flowers.
Okay, flowered slippers.
Flower power slippers.
I just want to review just how this all transpired and what the plans are, okay? And Taylor had kind of a difficult birth, and she got stuck. Doctors who were delivering her had to apply some traction on her neck, causes the injury to the nerves of the arm. We cannot make the arm normal, but what we hope to do is to restore these elements of these important movements. Let me just take a quick look at her arm before we go in. So these are the movements we're trying to restore. Bend the elbow and at least get the arm out and away. Yeah, it's okay. The incisions on her leg will be one here and then a couple little small ones here, so because the nerve is a long nerve, which means it's such an excellent source of a nerve graft.
Would you like to get cozy? Oh, is that tired, girl? Such a tired girl. Give me a kiss, baby. Be good. She's gonna have a good. Be good girl. Put that up. I'll see you in a little while. I'll let you know how things are going. Okay? She'll be good. Come on.
Okay, let's go. So we've prepped everything very extensively. We prepped her whole arm and her neck, and also both legs, which can serve as the donor nerve graft.
What that does is coagulates the
We're going to just start with the upper part of this, and that'll expose the whole part of the upper plexus so that we can get at all the nerve roots, particularly the upper ones. And then we'll only extend the incision down here if we need to look at the brachial plexus below the level of the clavicle. I think that's the muscle.
Careful though. There's a vessel there too. See, right there. Right there. It's coming right here.
So we've just identified the upper roots which join together to form the upper trunk of the brachial plexus. And the nerves look very abnormal and they're very woody. So we're just going to get organized and then we'll bring in the operating microscope and cut across the nerves and examine them under the microscope. And we'll also do frozen sections just to look at the quality because we want good quality nerve input and we want good quality nerve output for the grafts to have the best chance of working.
So let's pass this on.
We're going to move to the next phase, which is to resect this area of injury and then put in a nerve graft.
Okay, Todd, I think we're ready now.
All right.
Want to give Mama a quick hug and then we can get going? No? Okay.
See you, Kyle.
Bye-bye.
Bye, Mom.
Love you. Okay, see you. See you after. Okay, behave. This way. This way. Over here. Behave.
All right.
Okay. See ya. Love you, bye.
Bye.
Slippers.
It's a big guy. So why are we taking out his spleen? His platelets are abnormal. They're covered with an antibody. And the spleen is just doing its job, eating up things that have antibodies on them. Try and make the scar in the belly button because it's a good place to hide a scar. Good. Thank you. Put the scope there and we'll hook it up to the camera. Take the scope. Okay, so there's the spleen right there. Fairly big spleen. Most people with ITP do not have such a big spleen. So we use this to lift up the spleen. Now, that's very good. And then we just clamp that down, make sure that we've got everything. I think we do. Okay, so the spleen is completely disconnected. Now comes the next exciting part. We remove the spleen. And we've got the bag ready, the big bag. You can sew it up. Okay, so now just open the bag up like that. And then we have to try and get the spleen to go into the bag. It's a big spleen. It looks like it barely fits in the bag. We're now going to harvest the nerve grafts from the leg, which in some ways is the hardest part of the whole operation because this nerve is tiny and we want a very long piece of it. A bit more, yeah. Okay, there's the vein. And there's the nerve. Okay. The hard part about getting this out is dealing with the branches because they often kind of hold things up a little bit. But we'll go up to the top and I'll cut across it as high as I can go. Now, if there's any justice in this world, this nerve will come. No. See, there's the, I'm being held by a branch. That's what that's the trouble. Can I have the tooth forceps? Might be. So I'm going to take this out, okay? If you can take it like, that's perfect, okay. Okay, there's the nerve, we can't lose that. You can see the different branches of this nerve they all came out. These branches are good enough for a graft here, Raj. I think we're going to be okay. Okay, I got it. There. Nice.
Hi, it's Nicole in Dr. Drake's room for Mr. and Mrs. Duval for Taylor. We just have an update that everything is going very, very well according to him, so I just want to let you know. That's all. Okay?
And then Dr. Arne came at 5 after.
So everything has gone really well, and she's awake and she's kicking and looks good. So then we took both nerves from her legs. There's 2 incisions on each side. There's one here and one here. Same thing on the other leg. There's 1.5 to the muscle that does this. There's 1.5 to the muscle that does this, and there's 3 to the muscle that does this. So from our point of view, if anybody should do well from this operation, she's the one.
So she should be able to get...
We'll have to wait and see.
We'll have to wait and
but
see.
I think she has an excellent chance.
I remember, like, someone was saying that there's the 2 movements that they'll never get back. For some reason, that was doing this one and the curling of the wrist.
Yeah.
Someone said...
It's very hard to get this movement back.
Yeah. But so that's still...
Well, we'll have to wait and see.
For that too?
Yeah.
Okay.
Taylor's fine. She's sleeping. We gave her a couple of shots of morphine. And she was a little bit restless when she came in. She's done really well.
Surprised she's taking that.
The soother?
Yeah.
Yeah, she doesn't like
do it. No, it's the first time.
Yeah.
I can't believe that.
It's a big spleen. Okay, let's just see. Is it in there? Is it in the bag? It's in the bag. Okay, now we gradually close the bag. Okay, there's the bag. So the whole spleen comes out through a little tiny incision. I think we're almost there. There we go. Okay. And then we'll just put some tape on that, and we're done.
You can go right now. Oh, has he gone back to sleep? He's gone back to sleep. No, he hasn't. Now, can I put this down or not?
Morphine.
Sorry? Pardon?
Oh, more morphine.
You want more morphine, honey? Everything went great. Did you hear Dr. Meyer say that?
You get it all?
Yeah, he got it all. He didn't leave half of it there. He got it all.
Good for him.
Yeah. Hats off, eh?
Uh-huh.
Good for him. Are you warm enough?
I want you to take the cover off
Yeah.
to my waist. I want to tell you what I want you to tell me what my stomach looks like. I want to know.
Is that a concern?
Yeah.
Okay. I'm allowed to look under here with that box?
Well, okay, not far.
No, I'm not. Okay. Okay, there's 1 poke mark, 2 poke marks. You got a bandage on your belly button.
Are they still open?
No, honey. There's like 1 little suture in them. They've just got steri strips on them.
Okay, got it.
1, 2, 3, 4 pokes. And your belly button's covered with a pretty little, cute little bandage. And you do not have any boxers on.
Oh, naked.
And I'm sure they didn't lose those nice boxers, though.
Better not, huh?
Those are your fave ones, right?
I can dash the gown, but I want the pants and the boxers.
The silk Joes. Yeah? No, they're
Okay, stop looking.
No, I wasn't looking at that.
I want you to look at that.
Do you want to like have a sleep?
Yeah, I don't need any more morphine.
No, you just had some.
I know, I want some more. Fall asleep. Hi, morning. How's Taylor? So this sling is just to keep her hand at her side so she can't move it.
Okay.
And we can put a little opening so she can get her hand out. But we really don't want her moving her hand away from her side because the nerve grafts take about 3 weeks to really kind of get solid. So she has just sailed through, okay? She looks great. We'll take this out and we can pick her up, and she's gonna be tender, but she should be okay, and her feet look good. All right, so we'll just try and get things back to normal as much as we can today, and she looks great. Okay, thanks.
Hi, Taylor. Come on in. So how did it go with the sling, okay?
Not too bad. I had to take it off once because she threw up everywhere all over.
Oh, did
so
she?
Took one part off and put another
Complicated
part on.
things, eh? Yeah, hi. It's usually about the first 6 months, and hopefully by then she'll get back everything she had before surgery. And then after that 6 months, we should start seeing some new improvements, okay? So it's a bit of a waiting game because you really just have to let the nerves grow down back to the muscle. But the one thing that's going to be really important in the next 6 months is just doing all her stretches to keep her arm nice and loose. But I think her shoulders and her elbow and wrist will come out nicely. Yeah, I don't think you've lost any range. It's just a little tight right now because she's been in the same position. And just with some stretches, she should come right back out. Oh, there.
Okay.
A big hug.
Okay, give mommy a big hug.
Okay. All right, we're all done, Taylor. Look at that. The big
She constantly wants to jump it.
Does she?
Non-stop, eh?
Yeah.
Yeah.
Hey Todd, how are you? All right. You had an operation.
Yeah.
Does it hurt?
A little bit.
Not too bad though?
Not too bad.
Okay. Is he on some morphine?
I just upped it to 2 actually.
Yeah. Okay. And you can go home as soon as you're eating and off the morphine. But everything went great.
Okay.
Spleen came out. No problem.
All right. Great.
And obviously your platelet count has to be adequate too.
Right.
Right. And we're going to know pretty quick, aren't we? It should.
Usually within a couple of days, the platelet count goes up.
Does it really? Really? Okay.
The problem is not with the spleen. The problem is with the antibodies on the platelets. And when the platelets have antibodies on them, the spleen thinks that they're trash and tries to chew them up. So taking out your spleen doesn't fix your platelets, but it does stop them from being chewed up. So I'm pretty sure it's going to go up.
All right.
All right?
All right. When can I get back to hockey?
Anytime.
Anytime. So like tomorrow night?
Yeah, if you feel okay.
Really?
Yeah, I mean, there's no limit.
Okay.
It's just a matter of when he feels up to it.
Sure.
Tomorrow night probably would be a little early.
But next week.
I think you have to be off your morphine before you can play hockey. But,
Or maybe that's when you should play.
Wait, just give me a second.
Now that Todd's spleen has been removed, his platelet levels have improved. Todd is no longer in danger of serious bleeding from simple injury and is free to enjoy physical activity.
Hi, how are you guys? Recover from everything we did?
Yeah.
Okay, let me just check your range, okay? Oh, that's a girl. Yeah. That's a girl. Okay, well she's got almost all her range back, which is great. That's just what we wanted. And her triceps is really so strong I can hardly bend her.
Yeah.
And now the hard part, we just gotta wait and see.
Yeah.
Okay? So
The weeding game.
we don't really expect anything for about a year.
Yeah.
Okay? And we just gotta wait and make sure we keep her range in the meantime. That's really important. So the chances are great. Good.
Let's wait and see now.
Okay, so we'll see you in
Thank you
6
very
months.
much.
Okay?
Great, thank
Okay.
you.
Thank you. Bye now.
The first phase of Taylor's nerve graft has been a success. She will now begin a year of physiotherapy in the hope that as much movement as possible can be restored to her hand and arm. The following events were recorded as they happened at the Hospital for Sick Children in Toronto. In this episode of Life's Little Miracles, Daniela's struggle with epilepsy.
Know where you're going to be. 6C. That's right.
7-year-old Daniela has debilitating epilepsy and can suffer up to 30 seizures a day. Her seizures have been monitored, and she is now being considered for surgery to remove the part of her brain responsible for the epilepsy.
Those are coming from temporal lobe.
Daniela must first undergo an operation to place a grid of electrodes on top of her brain. She will then be tested to pinpoint her seizure center and determine where her language skills are located.
You know what?
You gotta loosen up a little bit better.
I gotta put this band on.
Doctors must be able to remove the part of her brain responsible for the seizures without destroying her ability to speak.
Let me cover up the fingers. Cover up the fingers. They do children all the time. Let's sit here.
I don't want
Okay,
to do
come here.
it.
Close your eyes. It's okay, you've got this. Sometimes you have to. Sweetie, you're okay. Now it's you on 3. Count to 3. 1, 2, 3. Good girl. Are you okay, sweetie? Good girl, Daniela.
And you know what? Now you get to watch Mommy and Daddy get it done too.
Oh yeah. You gonna hold their hands?
No, she's fine.
Good. Now,
You're done.
Mommy, do you want to just stay there? I'll do you
Yep.
next because you're right there.
Yep.
I know. You give Mom a big hug and you talk to her, okay?
Tell her not to look.
Don't you
Tell
move
her?
either, sweetie,
Tell her not to
okay?
look.
That's okay. You're okay, Vanessa. Nobody moves. Except
Are you
for
the
Mommy.
middle for me too?
On 3. 1, 2, 3. Okay, Mommy. Open up.
Open your fist. Yep.
Okay, don't move your hands any lower now either, sweetie.
I think
okay?
it's Mommy.
Mommy's brave?
No, Mommy has the same blood type.
You think so?
You think? That's what we're going to find out.
You got it.
Excellent. Now it's my turn.
I'm gonna hold your hand.
Oh, thank you.
On 3, Daddy. 1, 2, 3. Good. Thank you, ladies. That's cute.
Both of
Double
them.
ends away.
Mommy and Daddy has the same blood as me, right?
That's what we're finding out, sweetie.
Hi, sweetie. How are you doing? So today's the day when you can ask questions about the invasive monitoring procedure, which we hope to do.
Do you have any questions for the doctor? He's the one that's going to be doing the surgery.
Oh.
Nothing you can want to ask him?
Are you cutting the hair where the part you're doing?
Cutting your hair? Yeah, we had a nice talk with your mom and dad about that. So we're going to see if we need to cut your hair or not. That's a good question. The goal of the operation is to map the functional or critical parts of the brain so that we can find out where the seizures are coming from, yet spare important areas like her language skills, motor function, sensory function. That is the reason why we have to do this in 2 stages, right? So the first operation is to do the exposure, place the grid on the surface of the brain, record from that grid over a period of about 5 days, and then after we have mapped out exactly where the seizure focus is, and then remove the seizure focus without interfering with normal parts of her brain that are subserving important functions like speech, language, motor skills, etc. You'll be going through a protocol of being weaned from the anticonvulsant medications prior to the operation so that she has the best chance of having a number of seizures before the second stage. And we hope to capture between 5 and 20 seizures during that week of monitoring.
I know we've asked already some questions, but I don't think I asked this one. If there's any chance of brain damage with surgery, either one.
The answer is yes. The second stage, we're going to plan to resect the seizure focus. So by itself, even though that may cause some brain damage at that location, that part of the brain is not functioning normally anyway. All it's doing is causing her seizure, so it's best to get it out of there. Did you have any questions before we go ahead?
Just one question. Like, what do you do if she has seizures during the operation?
It's not uncommon for children to have seizures during the procedure itself, but fortunately she'll be under anesthetic and you won't have to worry because the anesthetist can keep things under control for us. Understand she's been having a lot of seizures.
Yeah. Right now we're averaging about 30.
30 a day?
A day.
That's plenty. It's time that we get on with things and to help her with her seizure problems. Okay, and I'll see you mid-afternoon, all right? Talk to you soon.
All the best.
All right, thank you.
You watch her for me?
I will do.
Okay, honey.
We'll
you have to go with Linda.
Yeah, do you want to give Mom and Dad a big hug?
I love you. You're gonna be fine. I'll see you in a little while, okay? Give me a big kiss. Big kiss.
Hey, sweetie.
That's a girl.
We'll see when it's all over, okay?
You get to open up the big doors. Would you like to open up those big doors for me? Okay. See that square button over here, Daniela?
Daniela?
Can you push this? Push it real hard. Oh, look at that! The doors have been closed.
There we go.
There we are. That's a girl. You bring Snowy? Snowy's so nice and snowy white, isn't he? Up here it is. D. Here we are. Come on. I'll be with you. It's okay. I'll take it.
That's good. Okay. You tight everywhere? That's good. That's good. Okay. So let's position so the head's up a bit. We've got to be temporal mostly and want it to lie mostly flat a bit. Okay, guys, let's try that. All right, gentlemen. So let's mark out our flap. So this is the actual size of the grid that will be laying on the left surface of the brain. We need suctions on. Okay, away you go. Let it go straight down, pal. Good. Nice. Lovely. And that should hang back. Now you got the whole brain exposed. Beautiful. Have a pickup, please, with teeth. Okay, just lift that up. I'll put this underneath. Okay, let's see where we are. Yeah, see if we can mark that. It looks like that may be the posterior extent of it almost. So on your 3D image, it looks like that's just at the back end of the spikes, cluster of spikes. There you go. Yeah. Nice. Okay, so now we just need to lay on the grid, right? Okay, gray on the grid. There we go. Okay guys, what do you think about this? So we have the grid underneath this numbered template with the wires coming out of it. You want to just do numbers, guys, or you want to do?
No, just one.
Number one?
Do numbers.
Yeah.
Number
okay.
one.
Yeah, that's a good idea. Number one, here's number one.
Right.
Just stand back a bit.
Good.
Okay, next one.
58, here it is. 58. Okay, looks good. Okay, we're going to close up. Bone flap. So we need a 2-0 suture for the bone. Do you have those?
Yeah.
You can tie these in. And again, these are going to come out, so it's just really just allow it to hinge. Okay, now we're passing the wires that are recording electrical activity from the grid through the scalp. Okay. That's great, guys. So what we plan to do from here is to finish closing. Patient will go to the intensive care unit where immediately today we'll start capturing electrical activity from these wires. And having captured many seizures, we'll be in a good position then to map out precisely where the seizures are coming from, with the hope that we'll be able then to cut out the seizure focus so that she doesn't have seizures anymore. So anyway, everything went great. We're just finishing now. We did everything we said we would. We did the exposure on the left-hand side, and we placed this large grid about the size of my palm on the surface of the brain. Now we're hoping that she's going to continue to have multiple seizures. She's been having many since the medication's been tapered off. With Daniela, we don't know, but we anticipate capturing seizures almost immediately, knowing what she's doing without her medications. Okay, any questions?
Nope, just around this corner here. She's had 3 seizures already. 3 seizures already?
3 seizures already? But you didn't get them obviously, right?
No, that's okay. If she's already revving up, it means likely she'll have some clusters. I think they're just in the process of discussing the medication, so I'm presuming that they're going to start the fentanyl pretty quickly for her pain. If she can sleep her way through this week, all the better. Kids have very little memory of this week.
Hey, sweetheart.
We're just talking about you.
We came to see you.
Yeah, I just came to say hello.
She looks so frightened.
Yeah.
She opened up that eye, she looks so frightened. She's gonna have a seizure. Bring it out of the way.
That's why she's... Okay, that's why she's...
Okay.
Actually, she was about to have it. That's why she awakened, I think.
Yeah. Oh, okay, then I'm here. Okay. Mommy's here. Okay,
There we are.
Mommy's right here. Oh, okay, there we go.
Oh, you just missed her seizure.
Oh,
about
another
10
one.
seconds ago.
Just now.
Yes. Very brief.
Okay.
She woke up with a very scared look on her face and immediately started.
Oh dear. How many is that now that she's had today?
1, 2. She had 8:05, 8:14, 8:23, and then 2 more. She had 12:12 and 12:50, and now 2 o'clock.
So she's having them in her usual little clusters, but they're fewer than she was having at home.
Okay, well she's really behaving like a champ for us with all these
She is. She's
seizures. I think she may even be setting a record for us. Irene, what do you think?
I think so. I think they're analyzing some of the data up there, and I wouldn't be surprised if after functional mapping tomorrow we'll probably, if we're
Yeah.
successful in getting her language, then we may actually be able to stop the
Disconnect.
monitoring.
Good. Okay, and then the plan from there is to map tomorrow, and then once we have the entire map, get together with you and discuss the possibilities for resection afterwards.
So you want to test some color in there?
Yeah. Okay.
Actually, we're going to do anterior first, so
Yeah, you need to speak into the mic.
You hold the
Turn
mic
it
up to
on
your mouth
just a
so we can
little
hear you.
bit.
46, but they'll just try these. We'll just say on after.
What color is this?
Red,
What's this one?
46 to 20.
brown, yellow, brown, red.
Good. What about this one?
What color is that?
Red,
And this one?
brown,
Good. And this one? What's that? Can you say that one?
red,
Good. And this one?
red,
Off. Okay, and that was...
yellow.
Yeah, yellow. But just as you were saying off.
Yeah, she didn't have anything here. It's unlikely she didn't have anything there.
We'll have to take the boys.
Yeah, I'll check. Okay, 66.
Okay, 66 to 20. Yeah, girls? All right, we're going to start up here this time. What color is that?
Oh, it's turned upside down.
Okay, what color is that?
Yellow.
What's that?
You thinking?
What happened? What color is that?
Purple.
Good. Perfect.
So that's it.
Good.
Yeah, 66. Daniela, guess what? We're through.
Dr. Sneed will bring you the prize.
That's right. Sometime.
Peace connection.
So we got all the information that we needed.
Yeah, Steve.
I think we're set up for 5 o'clock tomorrow to talk about things.
That was a special one just for you, sweetie.
Too tired to talk.
Too tired to talk now, eh?
You don't have to talk.
Yeah, you're finished.
No.
Okay, no more talking.
I think this is the last one.
Can you
You want more of the thing? Please. Okay, so roll. Fresh air. As fresh as can be.
How are you doing? Hi. So, Dr. Atsubo captured 70 seizures. She had 70. And the seizures come to one extent or another from all of this area of brain. But they're most intense in this area. Okay? Particularly in here. In here. And where you see the circles is where we got function. And in this area, we think that there is a small amount of language because this is the only place where she consistently made errors in the colors. When she was naming the colors, she made a couple of mistakes. And where we got the language is also appears to be involved. So what our recommendation is that we remove this part of the brain back to here, all of this, and then we put electrodes down and we see if there's seizure activity coming from here, and we see how things look, and then we make a decision at the time of surgery tomorrow about whether to take 66 or not. This is a real dilemma, whether to take this part of the brain or not, because if you took it, I think that the chances of her not having seizures and the surgery being successful would be greater. But there is that risk if we take this part that she would have trouble talking after surgery for a period of time.
If you don't take 66, what would her chances of seizure control be?
The best case scenario is that she's seizure free. The next best case scenario is she just has a rare seizure, which is easily controllable with medication. But there is the potential that this won't work. There's always the possibility that it won't work. But I think this is such an invasive and aggressive procedure, and she's gone through so much this week. I think that we need to maximize the chances of this working, and that's why the tendency of our group, our team, is to be as aggressive as we can, because this is really her last shot for seizure control.
Guess we'll go with your recommendation right now, huh?
Yeah. Okay.
All right.
Okay.
Don't forget Teddy.
There you go.
Morning, Daniela. Hi, sweetie.
Yeah.
But she looks good. And I heard that she was still having a few seizures, even though she's back on her medication, right?
Yeah. Last night, weren't her typical seizures. It was just like she'd hardly move at all, and her heartbeat would just go up and then come down. And then this morning she's had 3 of her more typical ones, but very short.
Okay.
And that's been since she had 2 earlier on at around 6 o'clock, and she just had 1 about 10 minutes ago.
Okay. Now she's having a seizure right now. Yeah.
And hopefully they go away forever, okay?
The surgery to remove part of Daniela's brain is minutes away.
Don't have that much longer to wait.
Although the focus of Daniela's seizures is dangerously close to her language center, the operation may be Daniela's last chance for seizure control.